guys, how are you? Today we are going to discuss about a very important topic in ophthalmology, that is cataract. Okay, after so many days I am going to do this video. Okay, let's start. So what is cataract? Where this word is derived from? Cataract came from Greek word cataractis. It is a degenerative process which leads to opacification of normally formed transparent fibers. Okay, cataract means opacity, lens opacity. Okay, so first we have to learn about lens morphology. Then we will go and see what are the types of cataract and what is the etiology. Okay, what is the pathogenesis and what is treatment for the congenital cataract today. Okay, today we are mainly focused on congenital cataract. Later we will discuss about acquired cataract, right? So this is the lens. So you know that lens has capsule and lens has cortex and nucleus, right? So this is the nucleus of the lens, and surrounding the lens, nucleus of the lens, we have lamellar part, and see there is a projection which is known as pyramid. So pyramid part of lens, and below the capsule we have this is whole capsule, and below the capsule we have subcapsular part, right? And this is anterior cortical, and the below one which is there is coronary part, peripheral cortical, and this is posterior polar, and as there is anterior capsule, we have posterior capsule also, right? So lens has epithelium anteriorly, which is anterior epithelium. Posteriorly there is no such prominent epithelium, right? So let's go and discuss about types of cataract. So they are congenital and developmental cataract. Another one is acquired cataract. Congenital and developmental cataract, so it occurs before the birth due to some maternal factors or due to any congenital anomaly in fetus. So before the birth it is occurring, so it is known as congenital cataract. So we have nuclear involvement is embryonic and fetal nuclear involvement. We have embryonic nucleus, fetal nucleus, infantile nucleus, and adult nucleus. So embryonic is the central one, and it has like layers, right? This is embryonic. Later we have fetal nucleus, after that infantile, at last at the periphery we have adult nucleus, right? So developmental cataract occurs from infancy to adolescence. Okay, opacities involve infantile and adult nucleus, okay, which are the periphery ones. Okay, coming to the etiology of the cataract, congenital cataract, idiopathic means cause is unknown in 33% of cases, hereditary in 1/3 of the congenital cataracts, inherited cases without systemic disorders which are autosomal dominant, and inherited cases with systemic disorders. What are the systemic disorders? Some may be chromosomal disorders like trisomy 21, which is Down syndrome, skeletal disorders like Stickler syndrome, and some CNS disorders like cerebro-oculofacial syndrome, renal system disorders like Lovis syndrome, right? So what are the maternal factors contributing to the cataract? So maternal factors are, one is malnutrition, right? Malnutrition, and second one is infections, third one drugs. Infections, what infections means? Toxoplasmosis, cytomegalovirus inclusion disease, drugs such as thalidomide cause phocomelia, corticosteroids may cause immunosuppression in the fetus, which leads to cataract, and exposure to radiation, right? And some are common familial cataracts are there, like cataracta pulverulenta, jonular cataract, coronary cataract, and total soft cataract, right? So these are the maternal factors. Coming to the fetal or infantile factors, one is birth trauma, right? Birth trauma. Any trauma to the eyes during the birth may lead to cataract, and deficient oxygenation during the passage from the birth canal. If there is any anoxia or oxygen is less, then there will be some placental hemorrhage which occurs, which Sometimes the placental hemorrhage is the cause of deficient oxygenation, and sometimes obstructed labor. This may be the cause of deficient oxygenation, which leads to cataract. Okay, some metabolic disorders and congenital anomalies like Downs, Loeys, myotonia dystrophia. Okay, and congenital ichthyosis, and ocular disorders associated with the developmental cataract are microphthalmus and lenticonus, okay, which is posterior lenticonus, anterior chamber cleavage syndrome, uh, prematurity, retina, and primary hyperplastic, persistent hyperplastic primary vitreous, okay, retina of prematurity. These are some of the ocular diseases associated with the developmental cataract, right? So we have seen, and common familial cataracts before only we had discussed that are cataracta pulverulenta, juvenile cataract, and coronary cataract, and total soft cataract, right? So what are the types? Now in clinical, what are the types? Based on the anatomical and morphology of congenital and developmental location, cataracts are divided into congenital capsular cataract, congenital polar cataract, congenital nuclear cataract. This is why we had discussed before only lens anatomy and morphology, right? So congenital capsular cataract we had discussed before. We have anterior capsular and posterior capsular, right? So congenital polar cataracts are anterior polar, posterior polar. Congenital nuclear cataract, cataracts involving embryonic nucleus, cataracts involving fetal nucleus, cataract involving all, okay, all nucleus like embryonic, fetal, infant, and nucleus. So cataract involving embryonic nucleus known as cataracta pulverulenta, like powdery appearance of the embryon lens, okay, powdery appearance in the lens. Fetal nucleus involvement, lamellar, we had seen before only. Surrounding the nucleus we have lamella, so lamellar cataract. Sutural and axial cataract. In this we have floriform cataract, coralliform cataract, spear shaped cataract, anterior axial embryonic cataract, and dendritic suture cataract. We will discuss this. Okay, cataract involving all means embryonic, fetal, and infantile nucleus. This is known as total congenital cataract. Okay, and congenital membranous cataract we have there in this, okay, in this category. Cataracts involving adult nucleus and cortex, we have coronary cataract and blue dot cataract. Okay, coming to the congenital capsular cataract, okay, anterior capsular cataract. In this we have non-axial stationary cataract. This is a non-axial stationary cataract. It is also a part of anterior polar cataract. Anterior capsular cataracts are mostly rare. If they are occurring, they will be associated with the anterior polar cataract. So they are a part of anterior polar cataract. Posterior capsular cataracts, which are associated with the means persistent hyaloid artery remnants, which are also a part of posterior polar cataracts. Anterior capsular cataract is a part of anterior polar cataract, and posterior polar cataract is a part of this posterior capsular cataract is a part of posterior polar cataract, and we have congenital polar cataracts. So coming to congenital polar cataracts, we have anterior polar and posterior polar. Anterior polar, the opacity occurs in the central part of the anterior capsule and adjoining the superficial most cortex. This central part and superficial most cortex will be involved here. Okay. So it may occur in the following ways. This occurs due to the following causes: delayed development of the anterior chamber. Opacity will be seen like bilateral, stationary, visually insignificant opacities will be seen in delayed development of anterior chamber in anterior polar cataract, and sometimes corneal perforation leads to anterior polar cataract, right? Acquired in infantile stage and follow contact of lens capsule with back of the cornea, usually after perforation due to the ophthalmia neonatorum. So if the baby has ophthalmia neonatorum, and after that there will be some perforation to the cornea, which leads to this corneal perforation. Okay. So coming to morphological types, we have anterior polar cataract. In this, we have thickened white plaque in the center of the anterior capsule, anterior pyramidal cataract, thickened capsular opacity which is cone shaped. The cone apex will be directed towards the cornea in anterior pyramidal cataract, right? Reduplicated cataract. Reduplicated means we will have transparent fibers, but above the opacity, so the opaque fibers will be buried in between the this is capsule. These are the transparent lens fibers. In here there will be opaque fibers, so the opaque fibers will be buried, right? So that buried part is known as imprint. Okay. Like thickening of the central point of the anterior capsule, fibers lying immediately beneath will become opaque. They will get separated from the capsule, and the buried opacity is known as imprint. Okay, together known as reduplicated cataract. Right? Did you understand this? Coming to now we will discuss about posterior polar cataract. Right. Posterior polar cataract is common small circumscribed opacity involving the posterior pole. It is associated with the persistent hyaloid artery remnants. Before we have seen posterior polar cataract, it is persistent hyaloid artery remnants, right? Mittendorf dots, persistent hyperplastic primary vitreous syndrome, and posterior lenticonus involvement will be there. These are the associations in case of posterior polar cataract. What are the types in it? Posterior polar cataract, we have stationary and progressive. In progressive, we will see onion oval appearance. Okay. Congenital nuclear cataracts. Now we are going to see congenital nuclear cataract. In that we had discussed cataracta centralis pallidenta in familial also. So here we are seeing that embryonic nuclear cataract due to the developmental anomaly, like decreased formation of the lens. Bilateral small rounded opacity lying exactly in the center of the lens. Opacity will have pulverulenta means powdery appearance. It does not affect the vision in case of congenital nuclear cataract. If it is cataracta centralis pallidenta, centralis means center there is some opacity. Okay, that opacity pulverulenta means powdery appearance. So this powdery appearance does not affect the vision. Coming to fetal nucleus. Etiology, if there is any fetal nuclear involvement, like lamellar cataract. In fetal nucleus we have seen lamellar cataract, we have sutural and axillary cataract. That part we are discussing now. What are the causes of this? Means genetic, familial, autosomal dominant causes there are. Environment forms which are associated with the vitamin D deficiency and hypocalcemia. And see there will be clinical features like zone of fetal nucleus surrounding the embryonic nucleus will be usually affected. So zone of fetal nucleus which is surrounding embryonic nucleus. Okay, embryonic nucleus, this is there. So fetal nucleus, this fetal nucleus zone which is involved here. Okay, which is bilateral and small linear opacities which are like a spokes of the wheel. We will see here. Okay, these are seen towards the equator. Sutural and axillary cataract, punctate opacities scattered around anterior and posterior Y-shaped sutures of the fetal nucleus. It is static form of cataract which is bilateral involvement, both eyes involvement will be there. So anterior axial embryonic cataract find out near the anterior Y suture of the fetal nucleus. May form the chalky bands around the Y sutures. We will have Y type sutures. Okay, right? This Y we have this anterior Y and posterior Y. So there will be fine dot near the anterior Y suture of the fetal nucleus, then it is anterior axial embryonic cataract. They may form the chalky bands around the Y sutures. There is bilateral involvement, and this is autosomal dominant inheritance. Then we had discussed floriform also we have there, coralliform also there we okay. So floriform cataract, opacities which are arranged, floriform means petals of the flower, like, okay. Coralliform cataract, anterior posterior spindle shaped opacity which gives an appearance of a coral, okay. Spear shaped cataract, lenticular opacities which looks like scattered heaps of shining crystalline needles, okay. Spear shaped cataract. Then dendritic sutural cataracts, like dendrites, the sutures occurring like a dendrites, okay. Third one, cataract involving all, like embryonic, fetal and infantile nucleus. Total congenital cataract, it may be unilateral or bilateral. It involves embryonic and fetal nucleus as well as infantile nucleus. Dense chalky white opacity is usually bilateral, and this cataract is non-progressive, right. So we have more to discuss. Hereditary causes, other causes like maternal rubella involvement also there. So what is rubella cataract? Maternal rubella infection during the first trimester, second or third month leads to rubella cataract, purely white cataract, progressive type of cataract. Lens matter becomes soft or may even liquefy, okay. uh, may cause congenital Morganian cataract. If the soft lens matter, if it gets liquefied, then it is known as congenital Morganian cataract. Cataractous nucleus harbors the virus up to 2 years. Removal of cataract may cause inflammatory reaction due to the virus particles, which may leads to that inflammatory reaction is like uveitis or endophthalmitis or iridocyclitis. Like congenital rubella prevention is maternal rubella vaccination 3 months before the pregnancy. If you are planning pregnancy, before 3 months of pregnancy, you should be going to have rubella vaccination, so to prevent this congenital rubella syndrome. So what are the effects of congenital rubella syndrome? Means the baby may suffer from ocular defects, the baby may have ear defects, the baby may have heart anomalies. So coming to eye, congenital cataract, salt and pepper appearance, salt and pepper chorioretinopathy, microphthalmus, cloudy cornea, poorly dilating pupil. Coming to ear defects, we'll have deafness due to destruction of the organ of cortex. Okay, sensory neural hearing loss. So coming to heart, patent ductus arteriosus and pulmonary stenosis, ventricular septal defects will be seen in the heart. So coming to congenital membranous cataract, it is total or partial absorption of the congenital cataract, leaving thin membranous cataract. Okay, it is a rare. In rare cases, there will be complete disappearance of all lens fibers, and only transparent lens fibers remains behind. Okay. Capsule will be remains behind, okay. So all total lens fibers, everything is disappearing, right, in case of congenital membranous cataract. So there is only transparent lens capsule is leaving behind. It may be misdiagnosed as congenital aphakia, which is associated with the Hallerman stiff Frankosis syndrome, okay. Cataracts involving adult nucleus and cortex are coronary cataract. Most common cataract, which is occurring about the puberty, involves adolescent nucleus or deeper layer of the cortex, right. Opacities like they will be arranged in the radial distribution in case of cataracts involving adult and cortex, cortex, okay, adult nucleus and cortex, right, involving the central encircling the central axis. Vision is unaffected. Associated with the large punctate opacities, marginally they may reduce the vision. Coming to blue dot cataract, this is also known as cataracta punctata cerurea. Cerurea means blue color. Most common type of congenital cataract. It occurs first 20 years of life. Characteristic punctate opacities in the form of rounded blue dots situated at the periphery of the adolescent nuclei. Right, deepest layer of the cortex is involved. Stationary opacities, large punctate opacities which are associated with the coronary cataract may reduce the vision. Okay, coming to next, management of congenital and developmental cataract. Okay, up to now did you understand? Okay, what will happen if first you have to detailedly understand the classification, then it will be easy for you to understand this. Okay, so management of congenital and developmental cataract, ocular examination, density and morphology of cataract. Okay, we'll see red reflex, what is the quality of the red reflex in the density, okay, which is seen on direct ophthalmoscopy. Before and we'll see this before and after dilatation of the pupil. Right, assessment of the visual function, it is difficult in infants and small children. Density and morphology of the cataract by oblique illumination examination, and obliquely we will place light and we will examine the cataract, and we will also do fundus examination. Special tests are fixation reflex, force, it is choice preferential looking test. Okay, visual evoked potentials, optic kinetic nystagmus. Okay, associated ocular defects are microphthalmus, glaucoma, persistent hyperplastic primary vitreous, foveal hypoplasia, optic nerve hypoplasia, rubella retinopathy. What are lab investigations we will do? Lab investigations will be done to rule out any intrauterine infections like TORCH, toxoplasma, rubella, CMV, herpes, and okay. Galactosemia by urine test for reducing the substances. Okay, reducing substance. Okay, galactosemia by urine, we should do urine test for seeing the reducing substances. Okay, like glucose, sucrose is not reducing, glucose, fructose, like that. Okay, and decreased red blood cell transferase and galactokinase levels, if there any decrease is there or not. Lovis syndrome by urine chromatography for amino acids. Hyperglycemia by checking the blood sugar levels. Hypocalcemia by serum calcium and phosphate levels, and we will do x-ray skull also to rule out any fetal anomalies. And prognostic factors are density of the cataract, unilateral or bilateral cataract, time of presentation, associated ocular defects and associated systemic defects. Right, coming to indications and timing of pediatric cataract surgery. Partial cataracts, small central cataracts may need non-surgical treatment with pupillary dilatation if they need. Normally no treatment is required for partial cataracts and small central cataracts. Just will ask for follow-up and regular checkups. Bilateral, in case of any decrease in vision, we will ask that. Bilateral dense cataracts should be removed early within 6 weeks of birth to prevent the stimulus deprivation, amblyopia. Second eye should be bilateral, means you should first doing one eye operation. After that you should give some gap and you should do second eye operation. Okay, within few days after the operation of the first eye. So unilateral dense cataract removed as early as possible after birth within days. Correction of the aphakia and prevention of amblyopia in infants will be difficult, so you should be doing within days only. Surgical preventions, surgical and surgical procedures are childhood cataracts. We will do extra extra conventional capsular extraction involving the anterior capsulorhexis. Okay, irrigation, aspiration of the lens matter or lensectomy will do. Lens aspiration you should be doing like manual or phaco emulsion. Okay, It should be combined with primary post capsulotomy in children less than 6 years of age. Anterior vitrectomy in all children below 2 years of age. Correction of pediatric aphakia. If there is any absence of lens, what you should be doing? You should be implanting the lens, right? There is aphakia, there is absence of lens, so you should be implanting some lens in the posterior chamber. If children is above the age of 2 years, child is presenting to you above the age of 2 years, you should be doing lens implantation in the posterior chamber, okay, during the surgery, IOL implantation during the surgery. Children below the 2 years come to you, then you will be giving them extended contact lens, okay, wear contact lens, bilateral spectacles. Later on you should be doing secondary IOL implantation. Primary implantation you should be doing earliest in case of unilateral cataract. Pediatric IOL size and design should be seen, and they should be considered, and you should be choosing a suitable lens, and you should be keeping to the child presented to you. Power is the main concern. So based on the growth of the eye and the power of the lens, and you should be selecting a suitable lens, okay. Size of the IOL greater than 2 years. If the child is presenting, then you should be choosing the lens of power 12 to 12.75. You should be choosing the lens of diameter 12 to 12.75 diameter for the bag implantation. Design of the IOL choice is foldable IOLs made up of hydrophobic acrylic material. Acryls of the IOL like cyclone, like that, aclon, okay. Previous one piece PMMA IOL with modified C-shaped haptics, preferably apparent coated, okay, apparent coated ones. PMMA IOLs they need bigger incision, so nowadays not recommended, they are. So power of IOL, emmetropia in older children greater than 8 years, under correction by 10% in children between 8 years of age, okay, and under correction by 20% less than 2 years of age child, associated, and it should be calculated biometric power for, okay, to prevent and for myopic shift you should be calculating biometric power, and you should be doing correction of any amblyopia is there or not in the child. That's all guys today about congenital cataract. Management is like you should be doing implantation of IOL in case of aphakia, or you should be doing ECCE if the child is below 2 years, and later you should be doing secondary implantation of the IOL, okay. And you should be choosing the foldable IOLs made up of the hydrophobic acrylic material, okay, like acryls of IOL, acyclone, like that, and preferably heparin coated PMMA IOLs should be. Nowadays not preferable because of larger incision. So what you have learned? We have learned in this, first of all we have seen the lens structure. We had seen lens anatomy, and we had gone to the topic. Congenital and developmental cataracts we have seen. Congenital embryonic we have fetal nucleus involvement, developmental cataract infantile nucleus and adult nucleus involvement, and we saw the causes like etiology and maternal factors. What are the maternal factors involved in congenital cataract? And we saw common familial cataract. Then we went for types, congenital capsular cataracts, anterior capsular, posterior capsular, congenital polar cataracts, anterior polar, posterior polar, congenital nuclear. We saw that embryonic nucleus, fetal nucleus, and cataracts involving the whole nucleus. And in fetal nucleus we had some lamellar, sutural and axial, floriform, coralliform, sphere-shaped, anterior axial, embryonic cataract, dendritic suture cataract, and cataract involving adult and adult nucleus and cortex. We saw coronary and blue dot cataract. Congenital capsular cataract, like we saw this anterior capsular in the non-axial stationary, it is posterior capsular associated with the persistent hyaloid remnants, right? Again we saw congenital polar cataracts, anterior and posterior polar. Anterior polar, the cause may be mainly, you should be ruling out any ophthalmia neodatum which leads to corneal perforation and which further lead to anterior cataract. And we saw morphological types of anterior cataract: thick and wide plaque in the center of the anterior capsule, anterior pyramidal cataract, and reduplicated cataract. In that we saw imprint, which is the opaque fibers which are immediately lying beneath the capsule get buried. Okay, that is known as imprint. And reduplicated cataract along with the two we had seen. Posterior polar cataract we had seen, which is associated with the persistent hyaloid artery remnants. Congenital nuclear cataract, we saw that centralis purulenta and powdery appearance may not interfere with the vision. And in case of fetal nucleus, we had saw etiology and we saw what are the clinical features, and we went through sutural and axial cataract. In that anterior axial embryonic cataract and posterior anterior axial embryonic cataract and chloriform cataract, coralliform cataract. We saw that spear shaped cataract, coralliform cataract, dendritic sutural cataract, and cataract involving whole nucleus. We saw total congenital cataract. And we saw then management of the congenital cataract, what are the lab investigations and everything we had. Saw what is preferable surgeries in case of children we had. That's it guys today. I hope you have learned something about cataract. I hope this is an interesting and informative session. Thank you guys, thank you for your cooperation. Thank you.